Hello, welcome and kumusta. Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversations. In this episode, what do we want to talk about? I know, let me share with you my experience working as a locum occupational therapist. Yes, that was quite exciting time of my career for a good number of years. I must have locumed for about 5 years when I worked in the United Kingdom. Before that, I was working in the Republic of Ireland and I was working in a neuro rehab unit in one of the counties, and then worked in Dublin as well. And I'd worked in continuing healthcare facilities, community rehab, community facilities. And that was one of the many experiences that I've had. Then after that, I worked in the United Kingdom. So you can probably tell that I wasn't trained in the country of the United Kingdom. And when it comes to the education system and the processes, it's something that perhaps we will be talking in the future episodes. But my experience has been totally different because my training was 5 years as compared to the training in the country, in the United Kingdom, which would have been 3 years. And it was really extensive. But like I said, we will talk about more about the education. I'll explore more about the healthcare or the education system in the United Kingdom when I come across with people who can talk to me about those things in general. And one of the major adjustments that I had to do when when I started working in the UK was getting used to the process, to the system, to the skills of your colleagues. Because when you qualify as an occupational therapist in my country, and I'm sure I've encountered that with some colleagues from Australia and New Zealand and South Africa, you are an ultimate therapist. It is such a badge of honor to be working as an occupational therapist because you come out in the end knowing so much and being able to implement and treat lots of things. And it is such a holistic profession that addresses the entirety of a good proportion of a person's job of living. When I first landed in the United Kingdom, I worked in a facility, and it was a shock to the system because what I know is not the same as what others would know. And that was a bit difficult for me. Sometimes people would call out, and there is ranking in here, there's banding. And at the time, it was a band 5. No, it's not a band 5, it's basic grade occupational therapist. And after 3 years, you can apply to become a senior 2, and then you can have a senior 1. So those would be the rankings. And then you can have your OT manager, your classic definition of managers. But those were the entire ranking. And then it just came about that KSF, or knowledge skills frameworks, was being implemented around the time. So all of the people in the NHS got a banding instead of the basic grade, senior 2, senior 1. So everybody got banding. Now, the intention of those banding really was so that when you explain yourself to patients and to therapists, that you would promote yourself as an occupational therapist. And that gives some equality and fairness, and it gives confidence to the patients because everybody is of equal stature and status, where whoever is treating them are all occupational therapists or are all physiotherapists. But we never really got to stay there. In the end, we still would want to be defined not just by occupational therapy and occupational therapy alone. Sometimes we want to define as I'm a specialist occupational therapist, or I'm a band 7 occupational therapist, or I'm a team lead occupational therapist, or I'm a highly specialist occupational therapist, or I'm a lead occupational therapist. But very those things are it's just a nightmare for me. It's so hard to remove that out of our psyche. But really, it would just be nice if we can just be defining ourselves as occupational therapists. That's it, the same skills. Now, when you qualify as an occupational therapist, you should be able to perform all the tasks and duty that entails occupational therapy, or the task and duty that is associated with the profession. And it's very simple. There's only 3 things really that you need to do. An occupational therapist needs to be able to assess. An occupational therapist needs to be able to identify the problems, plan and treat plan the intervention after knowing the assessment and doing the assessment. And then you need to be able to treat those problems that you've identified in the assessment. And then you need to be able to discharge people as well. So very simple. See, assess, identify what's wrong, find out the solution, treat, and then discharge. Repeat. That's it. Over and over again. Very simple and very straightforward. And when I started working, I was a little bit disillusioned by the setting. And that was actually quite good because you get excited coming from different places. You get excited that there are many rotations. There is orthopedics, there is neuro, there are some stroke rotations, there's hands rotation, there are medicine for elderly, there's rheumatology. Those are some of the things. And it excites you because you think that there is a lot of opportunity to learn specialist skills. And I was and still am very hungry to this date about what else is out there. And obviously, you go in, big hospital, and knowing occupational therapy, it's a profession that span the lifespan. You'd be excited about the cases that you'll come across with. And then I realized it was pretty much the same. And I've come to a realization that it really was the same. Regardless of the condition, whether it's an orthopedic condition, whether it is an elderly condition, whether it's amputation, spinal cord injury, head injury, anything, all of these things, when it comes to occupational therapy, our concerns are the same. Our concerns is about a person's ability to engage with the day-to-day things, and you pick those things that are significant to you. If you're working in the hospital, the 3 essential ones is personal care, getting out of bed, moving around safely, wiping their bottom, putting on their clothes. At the time, you can worry about meal preparation, but nowadays, you don't necessarily have the opportunity to do that because being able to prepare meals is no longer a requirement for you to stay in the hospital. And rightly, because we are now thinking about hospital being hospital, and it is for medical reasons. So you stay in the hospital if there's a medical reason. And if it is a functional reason and it's a functional concern, then you don't necessarily have to be in the acute general hospitals anymore, or the district general hospitals. And so that was my experience. So I saw it, and for the first year coming from the Republic of Ireland, I thought, okay, this is it. I think I've seen enough. Regardless of whether it is orthopedics or whether it is neuro, the symptoms will vary, yes, but it's the same. And your approach will just be few things. Your intervention can be restorative intervention. If it's neuro, then neuro techniques. That's what you would use. NDTs, POBAF, Brunstrom, PNFs, Rude, Carr and Shepard. So that's what you would use if there is a neuro influence or neuro factor in the case. Very straightforward. And it's the same whether it's head injury or spinal cord injury or stroke, yeah, or multiple sclerosis or Guillain-Barré. That is if you want to restore it. Yeah. Now, if it isn't, and it's a general condition of the elderly where a person gets deconditioned and you get fractures, or you have hands, for example, or you have any other conditions like surgical conditions in general, then the approach is pure and simple biomechanical approach where you address the endurance, you address the strength, you address the range of motion, and all you need to do is do repeat over. Very simple, very straightforward. This is me putting things in a nutshell, guys. For me, it is simple because I know it and I've seen it and it's straightforward. Now, and I thought, okay, this is one facility that I'm seeing. So I thought, okay, it doesn't excite me anymore to make any rotations. It didn't excite me anymore because I've seen it. And that was about maybe 7 years or 8 years into practice already. So I decided to become a locum. Now I'm going back to the original reason for when I started this. Oh, it was just 13 minutes of yapping for the preamble and the introduction. So I decided and I chose to become a locum for good few reasons. For my leisurely reasons was I wanted to see the country, and if I locum, I can have the opportunity to work and see the country and work in different places around the country. So that's one. And then I wanted to see how different places are run, different styles of management. I'm at that point where clinically I've seen quite a lot, and it's fine. It's okay. Yeah. And I just wanted to see how different places are run. And this is because back in the days, I owned a therapy center in the country where I started, and it was still running at the time. So it was being paid for, cases were being paid for by the American insurances, and then you get reimbursements. So from one country to another. So I wanted to see how different places are run, and I wanted to be able to travel around the country. And the pay was not so much of an issue. I didn't think it was an issue at the time. I wasn't saving any money. As long as you have something that you can pay for your bills, your rent, and you can eat, then that's it. I didn't have any family at the time, so there's no issue. So you can just travel about. So I did, and I did some locuming. And a very exciting and beautiful experience because when you were a locum, you were outside the politics of work. That's one. There's not a lot of meetings you need to attend to, and it's pure, wonderful, pure treatment and intervention. And all you do day in, day out is go in to work, see patients, discharge them, do everything that you can, and then come home again for the following day. I'm not waiting for any referrals at the time. As a locum, I'd go in the ward, and there's not a lot of time back in the days. There's no digital platform. So just go in, look at the file, start. All you need was a pen. Yeah. And you can start documenting, seeing patients, start documenting your sessions. And you go in, you get shown around the place, you'll be covering one ward or two wards. Then, yep, give me the folder or the book, because every department, there's always a book. Everybody has a book. And some of the technique that I've learned, I'm sharing with you some of the tips. I'd like to share with you some tips that I have learned over the years. I was never passive when it comes to patients. I know that patients will come. I know that eventually patients will be referred over to me as a locum. So the first thing that I do is I become proactive in picking up patients because there's not a lot of referrals back in the days as well. You don't, sometimes they write things down on a paper, but again, the system is different now with some digital clickety clicks. So that's the one thing. I was just proactive. I'd go in, I'd see patients, I'd have a walk. So that's tip number one. Be proactive about seeing the patients. The second tip that I can give is do a round, an occupational therapy round. When doctors are doing their rounds, what's stopping you from doing your rounds? You are also a professional. We are also professionals. You can do your rounds. And when I do the rounds, I do my screening. Screening is I eyeball each patient. And just by eyeballing themselves or patients themselves, you can see which one looked frail or not. And I look at them. Is this frail? Is this likely? I just put a mark on that one and I'll come back and I'll interview, I'll screen, perhaps talk to the patient, see how I can help. So that's tip number two. Do your rounds. And tip number three, there is in every place, there's always a whiteboard. They call it a whiteboard. It is a board where the list of patients are in. So if you don't know where the patients are, just go find a board somewhere. It can be stashed. Sometimes it's covered because of confidentiality, but it's there. So that's tip number two. Use the whiteboard to find your patients. And at the time, it was just an initiative where people put in EDD on the whiteboard. But at the time, there wasn't any EDDs or medically fit for discharge or any sections regarding physio or OT or social worker or equipment or pharmacy. None of those. But those are now the improvements in the whiteboard. But there's always a list. So have a look. That's the best place on where you can locate the patients. So that's the third tip. And another tip as a locum is you need to hand things over to a nurse. So another tip is in a lot of hospitals around the country, there usually is a coordinator. Either it's a nurse or a discharge coordinator, and they can be the hub of communication. If you want to rely to the team that you've discharged your patient after the notes, just mention it to the ward coordinator. Sometimes they take these things down. And if you wanted messages being passed on verbally, coordinators are the people to find. But make sure that you always write those things down in the notes. That's very important. Write it down. Okay. So that's another tip. What number is that? Is that the fourth one? Tip number 5 would be if you cannot find the nurse and you want to hand things over, most of the time, the ward has a handover sheet. And either it is in the format of a Word document, or if it's a typed document, usually it's a Word document, you can access it or ask a nurse to access it for you so you can type it down there. That way, you are certain that your message is conveyed. That's another tip. Tip number 5. Tip number 6, at the beginning or at the end or in the afternoon of every shift, there is a ward list. Stapled, paper, stapled. It's always given to everybody, to all rotating staff. So if you're an OT working and you want to know what's been happening, you want to be updated with what's happening, grab hold of that. This is the printout of the nurse's handover. So that's actually good. So be there, find the list. You'll have the same copy as everybody else. And then when you look at these notes, you know what the nurses know. Because it will always be in the handover notes of the nurse. Okay. So that's another tip. That was probably number 6. So that's tip number 6. Anything else? If you want to know what really is going on and a proper understanding of what's happening in the ward, it is advisable to start early, around 7:30, because this is where the nurses handover take place. So it's the night nurses handing over to the day nurses, and you sit down with everybody, be quiet, just be there, and then you can listen to them doing the handover. And this happens every day, and it's very helpful, very useful. For those of you who hasn't witnessed this, that's probably because you start at 8 or half 8, or you wait for another board round handover that's happening, or whiteboard meeting that usually takes place around 9 or 10 o'clock. And with that, you've already wasted a lot of time, not by intent, but just by the process alone. So if you start early and be in on that nurse's handover, you will get a very good handover of the current state of the place. Yeah. So that is that. What other tips that I can give you when you're doing a locum? Every now and again, you get stressed and you'll want some chocolates. There'd be drawers there somewhere. Okay? There'd be drawers, pull a drawer somewhere. There'd be a box of chocolate there. Okay? But don't take it all. It's for sharing for the team. Very simple tip. That's tip number 7, perhaps? What else? Okay. So it's a wonderful thing to be a locum. All you do is treat, assess, and discharge a patient, and you do it over and over again. And when I was doing my locuming, I am overseeing 3 wards at a time. I can see 3 wards at a time, and it's doable. That's why my tolerance for a person's capability, I know what people can be doing because I've been there. I've seen and I've done it. I have walked the path. So when people are saying that sometimes it's very stressful in the ward, it's very busy, but a person is only seeing 4 patients, for example, or are always responding late and always firefighting, that's because probably we were not there at the very beginning. So to stop being reactive in waiting for what people have said to you, or responding to a late referral or a last minute referral, the technique is to be there at the very beginning. And that's okay. It's the job. Your job is to help out. Our job is to help out, really. And this is a model that I am developing, the helping out model, or the framework of helping out, or the frame of mind where you have it in your head that you're a therapist to help out. You're not just helping out the patients, but you're helping out the unit, you're helping out the hospital where you're working at the moment. Helping out meaning help out on the flow, help out on seeing the patients, help out, make it easy for people. And what tends to happen if you don't have that, the other concept, which is a lot of the times I'm seeing, is that we see things as a job and that it gets given to us and it is something that we need to comply with. That's because we are passive. Last minute referrals, that's very stressful. You can't make any decisions. You don't know what's been happening. I still welcome it. If I work from 8 to 4 and I get a phone call at half 3, I still have time to see a patient at half 3. Usually these are just last minute confirmation to confirm that the patient is going to be safe to be discharged home. And yes, we can still do that. And mind you, there are people that are working up until 6 o'clock. So there's still a lot of time to do that. And all it probably takes is just a quick assessment or interview and quick functional review, which is sit, stand, walk, see what the patient feels, get them to do as much as they can, and find out what they feel. Sometimes it's just the confidence of the MDT members that they wanted confirmation from OT. Again, it's the concept of let's help out. So if you're there to help out, you wouldn't feel that things are being done to you. You would feel that you are there and that you are contributing. So that's one of the great things about locum. Once you're out of the work politics. Second, you find yourself very efficient. Third one is you don't really have to think about the situation. You don't have to really worry about things. Just work, finish your work at the end of the day. Another technique or tip that I would like to give is when you see patients, document it straight away. Yeah. And if there are actions for the following day, write it down so that you can carry it on the following day so you don't lose it. Document it straight away, because what will happen is you might think that you can see as many patients throughout the day and you would leave the last hour for documentation. That's never going to work. You think documentation is fast and easy. If you're using paper, perhaps it'd be easier. But with all the plenty of clicks nowadays, you just won't be able to do that. And the risk is you will forget, or you would mix some cases, and that is unsafe. So it's not a very safe practice. The pay was reasonable because if you don't work, you don't get paid. There will be times where there's going to be a lull when you are working as a locum. The longest for me was, I think, 3 months of not being able to work, and that was stressful. There wasn't any call anywhere. Few weeks, 1 week. As long as you're prepared to travel, then it's not going to be an issue. But if you're choosy about the place, that's going to be a problem. Okay. The other downside, one of the downsides of the locum job is, yes, after that, there's no certainty. There's no certainty as to where. And one downside for others is obviously we don't have control of where you want to be. And then the other downside is after a while, nobody knows you anymore. And while that is good in other places, like another country, doesn't really matter if nobody knows you in another country. I find that in the United Kingdom, when you're trying to get a permanent job, there's this thing called references. So somebody will speak on behalf of you regarding your clinical skills, regarding your timekeeping, regarding your professional behavior, and things like that. And as a locum, managers don't really pay attention to you. You are a worker. You're nice and pleasant and friendly with them on a social capacity, but you're there. You come and you go. The other downside is people don't ordinarily give certificates of work that you've worked in a one place. And it's all up to you to just write those things down. And it is sad, isn't it? I love collecting like souvenirs from different places, like certificates. From where I was trained, I got a certification that I worked, and that's it. It becomes part of the CV, rather than just when you do the application, you just put a date. So that's not a common practice, I think, in the country. So that's why when I looked after my OTD student, so I looked after an OT doctorate student, and when she left, I gave her a certificate of practicing her placement in the place where she did the work with me. And that's good because it can go and you can take that, and it's a certificate that you can put in your CV. So nobody knows who you are anymore. Okay. There you go, guys. Some of my experience, my personal experience as a locum occupational therapist. As a point of pay, I know people don't like talking about money, but at the time, if I was in a week just getting £780, I'd feel poor. That's how it was with the locuming job. And I remembered applying for a senior post while I was doing the locum job. and the post was obviously quite low compared to how I was, because I probably was making around the time, possibly net, around 54,000 net as a locum. And that's quite a big amount, wasn't it? But then again, there are some things in there. You don't have any sick pay, you don't have any other things. But that was then. I think nowadays there's a cap in the locum market, meaning they don't pay you over a certain amount nowadays. But it still pretty much was the same, I think, as compared to how it was back in 2007, 8, 9, 10, 11. Yeah. So overall, with locuming, I managed to see around 21 centers and hospitals in the United Kingdom, which was actually very good. And over the years, I have met lots of beautiful and wonderful people, fellow locums from Australia, from Canada, and I have met different people from around the country. And with the dawn of Facebook, every now and again, I still see some updates about what's happening with them. And it just makes you appreciate how big and how wonderful the world is, and how small you are in comparison to the vastness of what we can be experiencing. And it just makes you appreciate life even more. Things become a little bit smaller when you are at work and you think things are worse. Man, I wish you can see what is out there, because truly such a wonderful world out there. All right, guys, this is how. Thank you for listening to me. I hope you enjoyed and learned a little something. Again, I'm saying this is a personal reflection. This is a personal experience. It's not a position of anybody. I'm sharing with you some wisdom of my experience. So this would be in the concept of riot. This would have been a random information, or perhaps relevant information involving occupational therapy, which make this a riot conversation. Until next time, guys. Bye. If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.